Hey Insta fam, it's Dr. T here. How are you guys going? Tuesday, rocking it at, I think it's about 5 to 6. Sorry, a little bit late. But thought I'd jump on. Good to have you. Hey, I'm just going to jump straight in because I know there's a few questions that have already come my way. And I want to share something with you guys that was a commonly asked question that I got again today. And I thought, I must share that with everybody on a live. So the question was asked of me today. Do we ovulate alternate sides each month? Like, if you ovulate off the left side of the left ovary on 1 month, do I then ovulate off the right ovary the following month? And then what happens if I am lacking an ovary? Does that mean I only ovulate every second month? These questions I get asked all of the time. So I thought, do you know what? I'm just going to pop that on a live. So every single month, your body has this pre-programmed release of eggs. And there's a group of eggs that are kind of been pre-programmed to be released in that month. In fact, you're germinating groups of eggs coming through all of the time. So those particular eggs, there's a couple of barriers, hormonal barriers that they have to kind of jump over in order to then be recruited into responding to FSH, follicle stimulating hormone. So, and that the number in that group of follicles is very much correlated with your ovarian reserve. So as your ovarian reserve declines, a smaller and smaller number of eggs is released. So it's a group of eggs that come through. Now, within that cohort, each of them is responding to follicle stimulating hormone that is also very much dependent on the number of FSH receptors, which is dependent on LH. So it's quite a complex process. But to try and simplify it, what happens is they are all growing, and then one of them will often grow into dominance. And the point at which that follicle reaches dominance is around about 14 millimeters. Once it hits that 14 millimeter size, it will actually suppress the others. So it grows into dominance, the others kind of fade away, and then eventually through that negative feedback loop you get an LH surge and you ovulate an egg. Now, it doesn't matter which side, which ovary it comes from, it will be kind of a random process. So it's not that we alternate ovulation each month. It might be that one ovary just continues to generate the dominant follicle, but a group of follicles is always being released. And if you do lose an ovary for whatever reason, surgery, torsion, whatever, doesn't matter, you will still continue to ovulate every single month because it just happens to be that the group of follicles is only coming from one side. So it's a cool question. I've been asked it a lot, and I thought that it would just enlighten some people out there. Now, another question has also been asked by Georgia. I think the question was, can follicles continue to grow beyond 2.2 centimeters or 22 millimeters, and what is the smallest follicle from which you can get a mature egg? Well, the first question is yes, follicles can grow beyond 22 mils and still not yet be ovulated off, and so the point at which you will get ovulation is when you get that LH surge. It won't just spontaneously ovulate. You'll need to get the LH surge to undergo the final maturation process. And can you get mature eggs? What's the smallest size? Well, that's a really difficult question for me to answer because obviously we do collect eggs, but we don't necessarily assign them to follicles when we collect them. But I do know that follicles that are sort of 11 mils, 12 mils and less generally will probably be immature eggs, M1s or even GVs, germinal vesicles. Once it gets beyond about 14 millimeters in size, generally speaking, we would expect to be able to get mature eggs in that. And there is probably a bit of a grey zone in there, in that perhaps something that we measured as a 13 mil follicle can generate a mature egg. Something perhaps that we measured as a 14 might also generate an immature egg. So there's no hard and fast rules on that, but certainly they're kind of the parameters in which we use. I want you to also remember that we are using a subjective ultrasound measure to kind of a three-dimensional object, and we're measuring it in 2 dimensions. So sometimes we might not be exactly perfect when it comes to our measures, and that's where I think sometime in the future we're probably going to get to the point where AI is artificial intelligence is probably going to be more accurately helping us to determine follicle size and follicle volume. That'd be really, really exciting. So that was a really interesting question. I haven't seen any other questions come through. Has anyone else posted a question? Can't see one. If you've got one, do post one. Somebody else posted a question. Is there any point doing a laparoscopy for silent endometriosis? Well, I guess the first thing is, how do you know it's endo if it's silent? Well, I guess one of the presenting features of endometriosis could be infertility. So if somebody has infertility, is there a point, and no symptoms, so silent, this was the question, is there a point of doing a diagnostic lappy? Well, the first thing that we would absolutely do is a physical examination and or a very, very detailed pelvic ultrasound. So I would always send to a women's ultrasound specialist, someone who looks at this stuff, looks at the subtleties of the pelvis. You know, could there be some adhesions, maybe some thickening to the uterosacral ligaments, maybe there's a big endometrioma. Maybe there's immobility of some of the pelvic organs. So I would be doing that sort of detailed scan first. Now, we do know that ultrasound and physical examination is not very accurate when picking up sort of stage 1, stage 2 endometriosis, probably more accurate in picking up stage 3, stage 4 severe endometriosis. So if a pelvic ultrasound came back normal and someone had infertility, would I necessarily do a diagnostic laparoscopy to improve their infertility? I'm assuming that's the outcome because it's not for symptom management. It's certainly something that we would discuss. So if it depends on the age, it depends on male factor, it depends on how long you've been infertile. Like, there's lots of things to take into consideration when you are then subjecting somebody to a surgical procedure. However, there is data that does suggest that for mild to moderate, so minimal to mild endometriosis, so stage 1, maybe up to stage 2, but stage 1 definitely, doing a laparoscopy and treating the disease can improve spontaneous pregnancy rates in the 6-month window following the laparoscopy. That's what the data shows us. So in that kind of population, a young population where we know age is not an impact factor, perhaps in somebody who has been trying to conceive for only 6 months to a year, certainly not someone who's been trying for 2 years. I mean, that's an awful long time to wait. We might consider doing a diagnostic laparoscopy. What else could you do? Well, we also know that IVF will overcome the impacts of mild, even up to moderate endometriosis. And so some couples will quite rightly move straight to IVF and kind of bypass the need to make a diagnosis of endometriosis. So they're all options, and I definitely think worth discussing with your fertility specialist, but it must be in the context of your own individual situation. I don't think there's a hard and fast blanket rule for anybody on that respect. And I also know that you can sit around the table of 5 gynecologists and they might all have a slightly different opinion depending on their particular type of training. There are some really surgical gynecologists and there are some more endocrinological gynecologists. All right. Anyone else? Any other questions? I must be entertaining you well. No one's posted anything. Does everyone want an update? I know you're waiting with bated breath to hear about my update. I suppose I should give you a bit of an update. Look, I am feeling really well. I am day 14 post my first cycle of chemotherapy. You cannot see, because I have a little bit of makeup on and also a little filter, you cannot see that I have developed some really bad, like really bad. If I'm not too vain enough, I might even post a photo, but I've developed some really bad chemotherapy-induced acne. Can you believe it? Never had acne as a teenager, and now I have it all across my forehead and all across my cheeks. Yeah, it's quite uncomfortable. So apparently not very common with the type of chemo regime that I am on, but as would have it, I got it. And so now I'm on a nice course of steroids and antibiotics. So yeah, devastating. But you can also see that I have still held on to my hair. It is, however, only day 14, and the alopecia can really start to kick in at around about 3 weeks post. So here's hoping. I'm going to try the cold cap again next Tuesday, and I think there's, not too much padding here. Hopefully the coldness can get through to my scalp okay, and I might be able to hold on for maybe another cycle. That would be nice if I could hold on to my hair. I've quite grown used to the bob. It's good. Wake and wear works very well. Any other questions? Gosh, here we go, Georgia. I knew you'd throw one in there. Who else have I got? Joe, beautiful. Question option doesn't seem to be working. That's a shame. What should we do if ERA results all come back good and have suffered 6 losses in the last 2 years? Oh, Joe, I am so sorry. Well, look, yours is a very, very specific situation. We do know that recurrent miscarriage can happen in around, so that's where you have 3 or more pregnancy losses, happen in about 1%. But, I do believe that, and most fertility specialists would probably agree, that when there is a situation where there's more than just 3, like a significant amount, 6, 7, 8, there is probably something pathological going on. And it's really important for fertility specialists to go right back to the drawing board and go, is this an embryo problem? Or is this an endometrial receptivity problem? So the easiest tool that we have to look at that is to firstly look at the embryo, because we have this amazing ability to determine the chromosome copy number or aneuploidy status of the embryos using PGT-A. So most fertility specialists will firstly talk about testing embryos, and I think that's a really good place to start, because you want to know that the embryo that you're putting back. Now I'm talking about IVF, right? So you want to know that the embryo that's going into the cavity is actually chromosomally normal. Then looking at the endometrial receptivity, the ERA is just one thing. It's just one thing. I do think there is a place for ERA, probably in a population where there have been a higher order number of pregnancy losses. So certainly 6 would be something that I would definitely be having my bunny ears raised with. But it's really important to go and look at all the other things. Is there evidence of chronic endometritis? Could there be a hydrosalpinx? Have you had a tertiary pelvic ultrasound? Have you had it be investigated for endometriosis? Have you looked at all the endocrine things like prolactin and thyroid? Have you been explored for celiac disease? So I think it's really important that your fertility specialist goes back to the drawing board and goes and looks through any of those things: anatomical, endocrine, clotting disorders, male factor high DNA fragmentation, before you start to dive down into the really weird and wonderful things, sort of all of those immune conditions that are bandied about. But Joe, it is a really difficult thing. I'm so sorry you're in this situation, but yeah, going back to the drawing board and make sure nothing else has been missed. It's really important to do. Georgia, is it okay for your eggs to grow apart? Yes, I answered that before, Georgia, so you're going to have to go back to the beginning, because I answered that way back at the beginning. Okay. PGT testing came back 2 top grade embryos, both lost 2. Yeah, buddy, like I said, probably can't answer your medical problems here, but I would absolutely go back to the drawing board and have a look at all of those endometrial receptivity things. Guys, this has been great. I've answered lots of questions that have come through DM and a couple of questions off from here tonight. Anything else? Yeah. No, what else was I talking about? Oh yeah, the chemo thing. So I've got my next cycle starting next Tuesday. I'm actually feeling really good. I've got to go and have a couple of extra clips put in my tumor. Let's call her Karen for namesake. Sorry to all the Karens out there. Karen's got to so I've got to get a couple more clips put inside next to the tumor to kind of outline it from a surgical point of view. So that's it's not a fun procedure, I've got to tell you. But it's just something that a little local anesthetic, but hell, all you guys that have been through IVF, yeah. And do you know what? I have realized that there's some incredible parallels between going through the cancer therapy journey and going through IVF. And I have done IVF, so I do know that journey, but one day I'll tell you all about them. I've had some big aha moments along this journey to go, oh yeah, this is the same sort of stuff my patients are going through. So I know exactly where you guys are at. Any more questions? Ashlyn, what are the impacts of thyroid levels that are still within normal limits but towards the lower end? So I'm not sure what you mean by thyroid at the lower end. Do you mean a TSH at the lower end or a TSH at the upper end? I'm not quite sure. Thyroid function is extremely complex. But one of the things in the fertility space that we want to make sure of to reduce the chances of miscarriage and late stillbirth is actually ensuring good thyroid function. So the current guidelines is that if a woman has thyroid antibodies present and a TSH above 2.5, we like to treat you with thyroxine, thyroid medication, to bring that TSH below 2.5 to improve predominantly the late pregnancy effects, but also potentially miscarriage. So hopefully that has answered the question. Oh, do you know what, guys? I'm going to need to wrap it up. I'm on dinner duty tonight. My appetite has come back. It's fabulous. The only thing that still tastes bad, though, is water. It tastes like I'm sucking coins. My daughter says, when did you ever suck coins? But seriously, it's quite metallic. So my appetite's definitely come back and I'm on dinner duty tonight. So I'm going to wrap it up. I will join you next Tuesday. Have a wonderful Easter to all of you. I really hope you have a great time with your families. Be present. Do some grounding. Get your feet out in the grass. Feel the air on your face, the wind on your face. Be present with your families. Look after yourselves. Make sure you give yourself some downtime. Fill your cups. I filled my cup in the last couple of days. And I will see you on the flip side. See you next Tuesday.